So our next technical session, our first technical session, is on data and evidence-based decision-making. It will focus on empowering governments with effective data use to data-informed decision-making against malaria, addressing the challenges in fully utilizing surveillance data for planning and implementation. The chair of this session is His Excellency Dr. Tan Eang Mao, Under-Secretary of State, Ministry for Health in Cambodia. His Excellency Dr. Mao is the Under-Secretary. He has been instrumental in advancing the country's health initiatives, particularly in tuberculosis and leprosy control. Dr. Mao previously served as the Director of the National Centre for Tuberculosis and Leprosy Control, where he oversaw significant efforts in TB case detection and treatment, contributing to the country's achievements in reducing incidence and enhancing public health strategies. Our panelists for this morning are Dr. Champa, Director, Anti-Malaria Campaign, Ministry of Health in Sri Lanka. Dr. Champa is a medical doctor with a Master's in Science in Community Medicine from the Postgraduate Institute of Medicine in University of Colombo. She currently serves as the Director of the Anti-Malaria Campaign in the Ministry of Health, Sri Lanka. Our next panelist is Dr. Prayuth, who's the Deputy Director, Division of Vector-Borne Diseases, Department of Disease Control in the Ministry of Public Health, Thailand. Dr. Prayuth is a public health specialist with a doctoral degree from the University of Kentucky in the US. He leads Thailand's malaria elimination programs and global fund projects, including the regional artemisinin resistance initiatives. Dr. Wesley Donald is the National Coordinator, Malaria and Other Vector-Borne Disease Control Program in the Ministry for Health in Vanuatu. He has played a pivotal role in planning, implementation, and evaluation of malaria control and elimination strategies in the country. His work includes leading various initiatives and collaborations aimed at reducing malaria transmission and enhancing the effectiveness of vector control measures. And finally, our last panelist is Professor Manuel Hetzel, Infectious Disease Epidemiologist at the Swiss Tropical Public Health Institute. Professor Manuel is an infectious disease epidemiologist, research group leader, and head of the Health Interventions Unit at Swiss TPH. He is also an adjunct professor of epidemiology at the University of Basel. His work focuses on improving malaria control, such as vector control, case management, and targeted surveillance response strategies. Our moderator for this session is Professor Richard Maude, Head of Epidemiology at Mahidol Oxford Tropical Medicine Unit, Research Unit, who is also the co-chair of APMEN Surveillance and Response Working Group. Professor Richard is the head. Professor Richard has worked at Mahidol Oxford Tropical Medicine Research Unit since 2007, where he leads a portfolio of epidemiological research on communicable diseases, including malaria and dengue, combining surveillance data science, and policy engagement. Could we welcome our panelists and our moderator and for this next session up onto the stage? Thank you.
morning, everybody. Honorable Minister, Secretary of State, Undersecretary, Excellency, Executive Director of WHO, ladies and gentlemen. For all, on behalf of Ministry of Health Cambodia, I'd like to express my sincere gratitude to the organizer, Ministry of Health of PNG, Upperman, for the invitation and the opportunity. To begin with our session, ladies and gentlemen, welcome to the technical session on data and evidence-based decision making. It is my great honor and pleasure to be able to co-chair this very important session. As you know, ladies and gentlemen, similar to other major diseases like tuberculosis and HIV/AIDS, malaria control and elimination depend naturally on our ability to harness accurate, reliable, implementable, practical, and timely data. Understanding malaria burden, transmission pattern, and intervention outcome enable health authority and implementer to strategically target their efforts. This ensures that results such as anti-malaria drug, diagnostic, insecticide treatment bed nets, indoor ritual spraying, and community health workers are effectively deployed, particularly in high-risk areas. Moreover, data-driven decision-making facilitates early outbreak decision, rapid response measures, and continuous progress monitoring. It is the foundation of evidence-based policy and collaborative efforts aligning our action toward the shared goal of eliminating malaria. Today's session aims to explore effective strategy for maximizing the use of malaria surveillance data at district, provincial, and national, even down to the community level. Our goal is to provide key insight for enhancing response efficiency and facilitating informed decision-making in the fight against malaria. We will delve into practical approaches that can transform data into actionable, intelligent, optimizing resource allocation, as well as driving impactful strategy for malaria elimination. Ladies and gentlemen, this morning we are very fortunate to have Professor Richard as our moderator, as well as our esteemed panelists, as mentioned earlier about their view, Dr. Champa, Dr. Prayuth, Dr. Sudathip, as well as Professor Manuel. So these presentations that are coming out and panel discussion will offer a wealth of knowledge and leveraging data and related information to enhance our malaria control and elimination effort. I am very confident that the discussions and insight gained today will be invaluable in shaping and strategy moving ahead toward malaria-free. And finally, thank you all for being here. I look forward to a productive session. May I now hand over to Professor Richard to continue this session. I thank you very much.
Good morning, everybody, and thank you very much, Mr. Chair, for a wonderful introduction. So we've decided to change the format a little bit. We're going to start this session with some short talks from three of our panelists. So we have an introductory talk from Professor Manuel, who will go first. Would you like to go to the podium?
Good morning, everyone, and thank you very much for allowing me to speak here. I wasn't aware that I was first. I thought I could refer back to my colleagues on the podium and to all the smart things they said and then just say, I totally agree. So apparently I cannot. If I could have my slides, please. Yes, here they are. Okay, so essentially, I want to start off in that case with a couple of more general comments on the strengthening of surveillance and use of data for better decision making. And just to remind ourselves, why do we actually need and want surveillance data? What is it good for? Of course, we all know it's one of the key pillars of the global technical strategy 2016 to 2030. But it's always important to remind ourselves that we want data for decision making. Decision making at both policy and operational levels. So whatever we do in order to strengthen our surveillance systems and our surveillance data, we should always focus on the fact that we want to make best use of the data for decision making. So it should allow us to understand patterns of malaria in our countries, to understand trends over time. It should allow us to make a better choice of what we implement and where we implement the different interventions, and then eventually to also evaluate impact over time. Next slide, please. And in order to do that, we need to understand and decide what data is really needed for decision making. And I think the most important recognition is that as transmission decreases, as we're getting more successful in malaria control, we need to make a bigger effort in our surveillance. We need to invest more, we need to be more timely, we need to have a higher resolution. I'm advocating here also for a concept of minimal essential data. I'm advocating against collecting all the data that you can possibly collect and focus really on a choice of key indicators that are relevant for our decision making. If you collect data that you never use for any decision anywhere, it's probably not necessarily data that you absolutely need. Of course, you also have to think about the appropriate data source. Not all the data has to come from health facilities or from all the health facilities in the country. You have to focus on the data quality, the accuracy, and of course the timeliness. Next slide, please. And all of that is not possible unless you have a functioning health management information system. And very often, and you see on the left-hand side of the slide, the health management information cycle, very often we focus on the recording and reporting of data. But what is at least as important, if not more important, it's the analysis, the presentation, the interpretation of the data, and then the use of the data for decision making. And this is not possible without people. And this is not something to just make everyone feel good, but it's really important that we have the people with the adequate skills in the right places to not only record, but also analyze, interpret, and use the data. So it's the people, it's the procedures, it's the tools and the structures. All of this we need in order to have a strong surveillance system. We should have data that is accessible, data that's ideally integrated into an overall data repository or into an overall national health information system. We need to have the analytical capacity at the level where the decisions are being made. So let's say if you have decisions made at the district or provincial level, but you have analytical capacity only at the national level, that is a problem. We should also, just to mention that again, consider multiple data sources. It's not only the routine statistics that come from all the health facilities in the country, but there are many other data sources that you can draw on in a comprehensive health information system. Yesterday, the question came up, do we have information on bednet use in Papua New Guinea? Oh yes, we do have. The PNG Institute of Medical Research has conducted 6 malaria indicator surveys in the last, I think, 15 years. All the information is in there, and it's all part and parcel of a comprehensive information system, as is data from surveillance sites, from therapeutic efficacy studies, from insecticide resistance monitoring and other entomological studies. And all of this should come together in a system that is integrated, ideally, and that's accessible to those who need to make decisions. And last but not least on this, let's not forget, it's not only a Ministry of Health that has to make sure that the data is available. There's a multitude of partners that can contribute this, partners with different capacities, different strengths that can really support the program, the national ministries of health and the subnational departments of health in providing data for decision making. Next slide, please. And I would to just very briefly mention 2 important sort of approaches that are relevant when we want to make decisions. One is what we call subnational tailoring of interventions. So we all know that it's not good enough to do the same thing everywhere in the country. So we need to come to decisions. What would we do best where? And the principle of subnational tailoring is essentially the use of local data to determine the appropriate mixes of interventions in different areas at the subnational level. So it starts with the stratification of malaria risk, but also stratification of determinants of the malaria risk. And I've used some images from projects we have together with PNG IMR and the Health Department to understand where in the country the risk differs, how and what are the drivers of that risk. And then you can essentially discuss with the program what are intervention mixes, what are interventions that the country can consider for implementation in different areas, and then apply mathematical models to simulate what the effect would be of different combinations of interventions. And this is really something that can help countries and has worked in many countries in their strategic plans to make a more tailored decision on mixes of interventions at subnational levels. Next slide, please. And now, of course, as we get very close to elimination, it's no longer enough to just have aggregate monthly data, but we really need to have a system of individual case-based surveillance, a system in which every single case is recorded, because every single case counts if we want to eliminate the reservoir and really interrupt transmission. And what is important there is that we have not only a case-based surveillance system, but we have a system that links the recorded cases to an immediate response. For example, alluding to the Chinese 137 system that helps to investigate foci in the individual cases. And an individual case-based surveillance system is essentially, or surveillance response system, is the basis also for providing the data that's required for certification of malaria elimination, because for each case you need to know, is it a local case, is it an important case? So this essentially reflects what I said at the beginning, that as you get to less transmission, you need to invest more. You need to transition from aggregate measures to individual case-based measures. And what you need for that is the adequate skills at all the different levels, so the people that you need to support in order to make this happen. And last slide, please. And to just summarize this as a few key points. So in order to really strengthen malaria surveillance, you need to, of course, ensure that there's high quality and timely reporting of key indicators, so the most important indicators. And then apply, ideally, a subnational tailoring for higher impact and better use of the scarce resources that we have. But it's not only the generation of the information, it's very important that there's action linked to it. So there should be an evidence-based response system linked to the data that we generate, ideally involving all the partners that we have in the country. And all of this, and this is my last and probably the most important point in my opinion, all of this is impossible unless you invest long-term in strengthening a health system. Because again, what's at the center, that's the people. And you don't build the capacity of people within a year or two. It's a 10 or 20 years investment, and that needs, of course, funds and commitment. Thank you very much.
Thank you. So next I'd like to invite Dr. Champa, who's going to tell the experience from Sri Lanka in the post-elimination phase.
Thank you, Professor Richard. Good morning to everyone. Distinguished guests and all the honorable political leadership. Now, I am ready to talk about why integration during post-elimination phase is relevant for Sri Lanka. Next slide, please. I hope you all are aware about malaria elimination of Sri Lanka during year 2012, received WHO certification as a malaria-free country on year 2016. And elimination was achieved by effective implementation of early diagnosis and treatment using quality-assured malaria microscopy services and later rapid diagnostic tests. targeted vector control, and real-time surveillance and response for cases and vectors. The risk of malaria being re-established is high because of imported malaria cases and high vector densities. And the other thing is, the country has a rigorous program to prevent re-establishment of malaria. Next slide, please. The need for integration post-elimination. Low disease burden. Last year, we had 62 imported cases, actually around 50 imported malaria cases per year now. Need for cost savings, because low disease burden whilst maintaining an effective prevention and re-establish program should be. And malaria is moving from disease control to health security risk. Many opportunities for integration of malaria PR program with system because of synergies. I mean, vector control, vector surveillance with other vector-borne diseases, laboratory testing with other communicable diseases. Next slide, please. Elimination achieved within decentralized program in our country. Elimination was directed by the malaria control program, the anti-malaria campaign, and its anti-malaria campaign is a special program within the Ministry of Health, and it responsible for policy, strategy, and guidelines development and supervision. However, implementation of malaria control and elimination program was carried out by provincial ministers of health. Implementers were regional malaria officers, they are doctors who reports to the provincial ministry but are accountable to the central anti-malaria campaign as well. Regional malaria officers had their own malaria implementation teams, but few functions were already integrated with other communicable diseases. Example, lab diagnostic of malaria performed by public health lab technicians, also diagnose TB, leprosy, STDs, and filariasis as well. Next slide, please. Integration of prevention of reintroduction program. It's an ongoing process. It should be done gradual, cautious, and planned one. Functional integration at district level is given priority over structural changes. The central anti-malaria campaign is being sustained with a staff cadre that focuses on policy, strategy, guideline development, monitoring and evaluation and supervision. In most districts, the regional malaria officer integrates vector surveillance and with other vector-borne diseases. In districts where regional malaria officers are not present, vector-borne disease medical officer deals all the malaria works. Next slide, please. Sri Lanka experience with integration of disease control programs. Experiences in Sri Lanka and other Asian countries show that rapid unplanned integration leads to major disruption of programs and return of diseases that has been eliminated. Integration needs to rigorously monitored and evaluated. Central disease control programs must be maintained with even a lean staff cadre. Integration needs to be based on geographical overlap of disease prevalence, control functions, clear job descriptions of staff with task shifting. Plans for greater integration of vector-borne diseases, malaria, dengue, filariasis, and leishmaniasis are underway within the country. Next. These are the facts that why integration during post-elimination phase is relevant for Sri Lanka. Thank you so much.
Thank you very much. So Dr. Prayuth, you're next, and Dr. Prayuth is going to talk about the surveillance system in Thailand.
Good morning. I am Prayuth Sudathip from Thailand. I have some few slides to talk to inform you about national malaria surveillance for malaria eliminations in Thailand. So the title is Last Mile, but for Thailand, I will tell you what's happening in Thailand. Next slide, please. Next. So the Thailand malaria elimination surveillance have established since we implemented malaria eradication program in 1965. It was the paper base. We collect individual data, investigation data, and foci classifications data. But the eradication program wasn't successful, and then we back to malaria control until we implement malaria elimination in 2016. The surveillance system was upgraded into electronic base during we implement containment project together with colleagues from Cambodia in 2008, but at that time we have two parallel systems actually, which is vertical program and general public health program, which is collect data from hospitals. And then at that time we need to integrate these two systems into one system in 2012. And after that, our malaria elimination surveillance system become one database, which is we call Malaria Online. It is currently is nearly real-time information system, case-based. We collect informations, case report, individual case, and case investigation data and case classifications, foci classifications. In this database also including vector control data at village household levels and the vector surveillance, including we use these informations for the monitoring of efficacy of anti-malaria drug anti-malaria efficacy in Thailand, which is we call integrated drug efficacy surveillance. We also use this data to monitor interventions at the village levels. So normally we use this data for both for epidemic detections at village levels and also for area stratifications at sub-village levels, and use that data for plannings and budgeting allocations, and also use that data for monitoring interventions, and also for purpose of at the last mile for verifications of malaria eliminations in Thailand. So you can go online with this website to looking at our database for malaria eliminations actually. Next slide, please. This is progress of malaria eliminations in Thailand currently that we use that data. I would like to emphasize that malaria in Thailand is notifiable disease, and we use surveillance data as the core interventions, using completely using 137 strategy, which is applied from China, and it has been successful in during we implement the malaria eliminations until a few years ago. We have some problem with along the border, but anyway, for the progress of malaria eliminations in Thailand, we make good progress in the eastern part of the country. We be able to verify of malaria-free for 49 provinces out of 77 provinces actually. But even though we do that, we still see a number of provinces that have newly transmissions after we certify or verify malaria-free area. So in this year, we are going to verify 2 provinces along the Thai-Lao border and Thai-Cambodia borders. And we also use that information as we found the reintroductions in the province that we already verify malaria-free. So we start thinking of how to prevent the reintroductions or re-establishment of malaria in where province that we verify malaria-free already. So we call subnational preventions of re-establishment of malaria in Thailand. Next slide, please. So as I mentioned before, the implementations of malaria eliminations in Thailand was good until 2021 when COVID-19 released, and we have conflict along the international border in Myanmar. So the case start increasing dramatically in 2022 to 23. We have 3,000 cases in 2021 actually, and last year we detect 16,000 cases, but more than 60% of cases are migrants from other countries. So the case still very high along the border, which is resulted from the conflict from other countries. And the four-side border is very critical actually, because along the border there is no fence. Some villages half in Thailand and half in Myanmar. So implementing of malaria elimination in only along the Thai border may not be appropriate for malaria elimination in these regions. Next slide, please. This is how the border foci malaria look like. So it is the same foci actually. So if we are going to manage malaria, we will need to manage foci beyond border. We cannot do only in single sites. So because along the border is not between Thailand and Myanmar, there is no fence like China, Myanmar, or India, Myanmar, because we have 2,000 kilometers together with Myanmar, so it's really impossible to control movement of people along the border. That the pictures showing that people working in that area. So some Thai community, they have farm in Myanmar side, they go to do farm and come back. Some children from Myanmar go to Thailand to study in Thailand in dormitory, and then during the weekend they go back home. So the transmission along the border is still very intense actually, and the conflicts and the movement, occupational movement is very high along the border. And in Thailand, we cannot close border. Actually, we still need some labor to work in Thailand because we don't have enough work to work in Thailand. So that is the pro and con, and difficult to control disease along the border. Next slide, please. So in these situations, how do we address? Because it's very high cases, and the majority of cases are VIVAX. 96% of cases are VIVAX, actually. So what we try to do, to use information how to implement, to be successful in malaria eliminations. We know that it is the VIVAX outbreaks. We get recommendation from many partners, or why don't we use chloroquine MDA to rapidly reduce burden of cases. But things not easy, because when we do community consent, there is no acceptable from community at all, especially from technical people. And in that situations, it's very high movement. So chloroquine MDA is not working in that area. So what can we do? We do feasibility study of tafenoquine in Thailand, and then because this is the VIVAX outbreak, so we think that radical cure for VIVAX may be better choice for us, and then we using tafenoquine together with G6PD quantitative testing, and then to implement along the border in 8 provinces to reduce. We already trained our staff and provide G6PD testing, and we just got the medicine to be ready in Thailand. Actually, we want to start this project quickly, but due to the procurement process, the tafenoquine is very high cost actually, and currently, and also the G6PD testing quantitative is also very high. Even our government tried to invest on this, but make this to equipment available in country, it's a very challenge for us. So, but anyway, we will implement tafenoquine radical cure in Thailand this month, and then roll out into community level later in next year. Next slide, please. So what are the activities that we are going to do? We want to use the mobile technology to mapping malaria foci and household level to improve quality of foci management. We implement this in the last few years. It was very successful actually, because we can mapping household and monitor intervention in each household. But unfortunately, we are not able to purchase tablet to replace the old one in the last few years. So this project stopped, but we already purchased new tablets. So this project for foci management using the applications that Esrabit and developed by Shai will help us to manage malaria foci especially in malaria elimination province. Next slide, please. So I would say that in Thailand we have a lot of challenges to reach our goal in 2026, because we still a lot of migrations along the border. We will need to manage foci beyond border, which is need more collaboration with partners, especially from Myanmar. And also currently we will need to think about how to sustain malaria elimination program in Thailand. So you need to work with local communities and to do prevention of reintroductions or prevention of re-establishment of malaria in Thailand, in all provinces, to be able to reach the goal, which may not be a few years, maybe after Laos and Cambodia and Vietnam. I think that's the lesson learned from Thailand. Thank you.
Thank you very much, Dr. Prayuth. So we're going to turn to questions for the panel. So I have some questions, and then we'll give you a chance to ask questions as well. I have about 20 minutes for that at the end. So I'm going to turn to Dr. Wesley next. Good morning. Dr. Wesley, we're going to hear about the Solomon Islands. So can you outline the key components of the surveillance system and its role in decision making?
Okay, thank you, moderator. I think, firstly, I would just like to acknowledge the PNG government for actually hosting this meeting here in PNG, and also acknowledge the APALM organizers for actually hosting the meeting here in PNG. I think I also just want to, on behalf of the ministry and all in program in particular, we also like to share our condolences to our colleague here in PNG, late Leo. He's a very good friend of us, and we've been working together for the past years. In terms of the surveillance system in Vanuatu, Vanuatu is actually moving from case-based surveillance. So it's almost similar to what other Asia-Pacific countries have actually been implementing. Like in China, it's 137, and also Thailand is also using that same case-based surveillance strategy as 137. Vanuatu, we are using the 1760 strategy. So this is based on the geographical locations of the islands and how easy or difficult to access logistics in terms of providing response to cases. So we on that strategy, like for case surveillance, we're using case detection and case notifications, and that's normally done in day one. So one is case detection and case notifications on the health facilities. And day 7 is actually conducting the case investigation and classifications. So that is when the team actually goes out to where the cases are and trying to conduct case investigations around the case, and also conducting reactive case detections around the case within a range of around 500 meters. And if they were to find a case, then they go further than that, as to around 700 square meter. And then they were to classify the cases, whether imported or local cases. And most of the cases that we've actually reported within the last year is mostly local cases. And we also have imported cases, but we have some imported cases from other Pacific Island countries, especially those that have actually coming for studies in Vanuatu, some of the students in the Solomons and PNG. And also we have imported cases just within the locality itself. And the day 60 is actually for case follow-up assessment and also monitoring to confirm the completion of the radical treatment. So that's for day 60s. And that actually helps us a lot in terms of providing some decision making on how we can be able to identify and respond to cases in a timely manner. We're using the case-based surveillance systems that we actually have at the moment. So with that, it's not, we still also have some challenges in terms of conducting this case-based surveillance. As we know, some of the cases are hard to, in areas where it's hard to reach areas. You have to cross mountains or even rivers to try and conduct case investigations and all this. Funding is also something that is also a challenge for us, and I think our Secretary General has alluded that yesterday, that funding is a challenge for the program, to try as much as possible to respond within 7 days to conduct the case investigations. Also, we have this issue in terms of the treatment compliance. That's for day 60. Treatment is something that it's really hard to monitor, especially the radical cure for Vivax using the 14 days Primaquine. It's something that we have been having some challenges with. We've seen that patients only take HCTs for the first 3 days, and then after that they feel okay, and then they don't even take Primaquine and all this. So we're actually looking at other options on how to improve this treatment regime. So I think I'm glad to hear that Thailand is actually trying to look in other areas on how to actually look at other treatment regimes, such as the tefenoquine is also an option that we've also looked at. Yeah, so I think this information is really helpful in terms of providing some decision making within the country. So with the number of cases that has been reported, last year is just over 1,000 cases, and it is compared to 300 cases within the last 1 or 2 years back. And we already know that there were some unforeseen circumstances like COVID and all this, so it came and then it actually disrupts some of this system, so we have to fall back at some states. But that doesn't actually stop us. We have been consulting with the provincial health administration officers on trying to come up with an operational stratification plan. So that operational stratification plan that we developed is actually based on the number of reported cases that has been reported in active foci areas in 2022 and 2023. So we're actually just moving back 2 years back to try and see which are the active foci areas that we need to concentrate on based on the information that we've collected on a monthly basis. So just for our information, Vanuatu is actually making up of 6 provinces, and Tafea is actually eliminated since 2017, and we're lucky with that. We still prevent reintroductions in Tafea, so that's already a bonus for us. We're just concentrating on the central provinces and also the northern provinces in the country. So based on the information that we have, we managed to categorize this in 2 different areas. So we have a high burden provinces, which is in the north, which is Torba province, that's towards Solomon Islands, and also Sanma province, which is the biggest island in Vanuatu. Whereas the other provinces in the central islands, the number of cases is still low, and they're still able to manage the malaria cases in there. So we've actually stratified these cases based on the information that we've collected, and then the decisions we then to discuss with the ministry on what are the response strategies in terms of the activities that needs to be conducted to some of these areas. That's in the areas of case management, surveillance and response, vector control, and community mobilization activities. So these are the key interventions that we've actually come up with based on the information that we've collected with support from the DHIS2 system that we have. And it's a very strong system, even though we are still developing in terms of trying to consolidate some of these informations, but we are there. And we are hopefully that we'll be able to get the system more updated in the future. So yeah, this is where we are, and these are the decisions that we make based on the information that we collected in the provinces. Thank you.
Great, thank you. So turn to Professor Manuel. I wonder if you can say a bit more about different ways to strengthen disease surveillance and data analysis, particularly for targeting of interventions.
Hello? Yes. Yes, I think it goes back a little bit to what I also mentioned before. I think it starts with really a consideration of which decisions have to be made at which level. And then to ensure that there is data at a resolution that really helps the decision making. So that, again, the closer we get to elimination, like in the context of Vanuatu, and you need to have a case-based surveillance system, of course you need to make sure that this is absolutely complete. There is a very swift response to it. And then there are considerations that go a little bit beyond the collection of the data. We have seen in other settings, for example, I work a lot in East Africa, and in Tanzania there is a lot of asymptomatic sub-patent carriers of infections that if you have a surveillance system that relies on RDTs, you might not be able to detect these cases. So there's considerations on whether to increase the sensitivity of the tool or then to change the response and say, well, we do focal drug administration, so MDA versus test and treat. But I think the most important thing in any of these circumstances is that there is a clear protocol for what happens with the data in this process of collecting, analyzing, and then making a decision and implementing a decision. I think one of the few pitfalls is that if you see surveillance only as a system that collects data, if you're a health worker, let's say, who collects and records data every single month, but you never see a use of this data, it's not going to be a priority for you. So how can you make it a priority for the people who are involved? I think the best way is if the people also use the data. So if you have systems that allow the people at the different level to really make best use of the data, there's a protocol for regular analysis, and there's a protocol and a system for taking decisions based on the data, that probably also improves the way that the data is collected and the quality of the data.
Great, thank you. Dr. Champa, we'll turn to you. So you talked about integration, and clearly there's some challenges there. We talked a little bit yesterday about resource constraints as well. I wondered if you could say a bit more about the challenges for maintaining surveillance.
Hello. Yes, actually, if I talk about surveillance data is not integrated, but up to some extent, our vector surveillance data is integrated in malaria and dengue as well, but doing two different diseases separately. And reason is not integrating with other diseases. That means malaria required granular data based on specific variables and specific to that particular disease. Difficult to integrate case data between disease data. As example, malaria surveillance required travel experience, travel contacts, but those are not relevant to dengue or leishmaniasis or other vector-borne diseases. In PUR phase, malaria cases need detailed case information, what is highly specific to malaria, and action is taken only based on those data. Why I am talking about integration? Because currently we don't get any support from any agencies. We are getting prophylaxis drugs and other commodities with the support of WHO, but with greatest difficulty, our government is bearing the expenses for malaria prevention of maintaining POR phase. So to maintain our POR phase, we need to have some support. So that is why I am suggesting the disease integration is more relevant during this phase. Yes.
Thank you very much. Dr. Prayuth, I wonder if you could tell us a bit about how the Thai system has evolved over time, surveillance system.
I think in Thailand, since we implement malaria eliminations, we include the malaria as the notifiable disease under we call Infectious Disease Acts, and the malaria has been classified as the disease to be eliminated by the collaborations of international country actually. So before our surveillance system, we use only from vertical programs, and after we implement malaria eliminations, we combine between the database malaria surveillance from vertical program and from general public health into one database, which is the huge the achievement for malaria eliminations actually. And after that, we apply 137 strategy, which is the adapt from China, and use our dashboard to monitor the interventions in each foci actually, and use that to planning and also to allocate budget for malaria eliminations. And currently we still have a lot of challenges actually, because we have migrants and it's very high movement, and using like conventional the microscope to detect cases is very difficult, because they are very very high movement along the border. It's daily cross border, weekly cross border, and illegal things. So currently we have like VIVAC outbreak. Using RDT may not sensitive enough to detect case actually. So that we will need to think how to utilize the community to help us on how to detect cases along the border, especially for mobile migrant populations. So that Thailand, the surveillance system is evolved, and then we will need to try new strategy to do that. And using information may not be in Thailand only may not be enough. So we will have to utilize information from other part of the country. Luckily, as Dr. Ratanachai presented yesterday, in Mekong region, we have platform to share data we call Mekong Malaria Elimination Database. That data has been used at local levels to control malaria along the Thai-Myanmar border now.
Great, thank you very much. I'll go back to Dr. Wesley. In Vanuatu, apologies. Just going to ask you a bit more about the obstacles and challenges that you might have faced, particularly in collecting and using malaria data.
Okay, thank you. Yes, I think some of these challenges I think I've already mentioned. But I think the other one is if we were to use informations on hand and all this, then we need a real-time information. Accessing timely informations from the lower peripheries is still a challenge for us. We still have infrastructures problem, and communication is one. We are yet still using the paper-based malaria line list, in which the health workers, they tend to fill that and send the reports on monthly basis. We're trying to digitize these to electronic forms and all this. But the challenge that we have is that the coverage of the communications is still a challenge for us. So it's something that we're actually looking at. And I think the other challenge was also to do, I think that I've already mentioned that, is to access the funds in a timely manner so that we can be able to respond in a timely manner. I think this is very important in terms of not allowing the transmissions to actually happen. So the more time that we spend in planning and budgeting and all this, and then we also give a chance for the vector to actually continue to transmit the parasite as well. So even though we can have the case-based surveillance as 760, but sometimes we tend to respond even 2 weeks or even 3 weeks after that. It's just because of the funds that has not been decentralized. It's mostly centralized at the national level. So I think it's one of the things that our Director General has alluded yesterday on how we can be able to decentralize some of these funds from the national to lower periphery so that we can have these real-time informations, and also so that the team can be able to respond to cases in a timely manner. And we just had some discussions also last week on how we will be able to, we will be reducing the number of the follow-up, the day 60 to be reduced to day 14. So it's one of the revised date that we have actually looking at. It's just because of the durations of the treatment for the primaquine, it's within 14 days. So we reduced that day 60 to day 14. But we're not really sure. I mean, logistic difficulties and all this, HR, it's also another challenge that we're actually looking at. But we've already had some discussions with our development partners, UNDP as our principal recipient, and DFAT, and also other partners, WHO, on how they can be able to support us to respond to this case in a timely manner so that we will be able to manage our cases from time to time. Thank you.
Great, thank you. Professor Manuel, we turn to you next. So you've got experience in a few different countries over your career. Just wondered if you could say a bit more about some of the common pitfalls you've seen in malaria surveillance.
Yeah, I think probably many countries have seen one of the main pitfalls is that surveillance is not the priority. The data is collected and it's appreciated that it's been collected, but I was just thinking before, if I was the manager of a supermarket, I would want to make sure that the data on which products I sell and how much I sell is accurate, because I know I need to order again, and my profit in the end depends on that. So I've got an inherent interest in making sure that the data is of good quality, it's timely, and it's because I need to use it. So I think the most important thing is that there really is a recognition that data is a good basis for making decisions. Another point I think relates really to the systems and the integration of systems as well. I think we see too many places where different systems are being set up for different diseases. They're set up for projects, they're set up with a relatively short timeline. I don't think that there's a need to reinvent the wheel. There are many countries that are, for example, implementing DHIS2, and I'm a strong proponent of that system, but it's not the only one. But I really think it's important that whatever system is being implemented, it's a system that can be managed by the people who you have available, that can allow the decision makers to access the data at all the levels where decisions need to be made, and that allows for integrating different data sources. So, for example, not necessarily only the data that's coming from health facilities, but maybe also data that's coming from surveys, that's coming from therapeutic efficacy studies, etc. So this integration of the data, I think it does help, and I believe it is possible, even if you have a different resolution for malaria than for other diseases. There are systems that can really allow that. And then, of course, the long-term funding to develop, set up, establish these systems and maintain these systems, this is very important. And again, this does not work via short-term projects. It's really long-term investments into health systems. That's absolutely crucial there.
Thank you very much. Turn back to Dr. Champa. Just going back to integration, I wonder if you could say a bit more about integration of surveillance data. So how would you receive malaria data, and how is that combined with other data from other diseases? So just if you could say a bit more about the malaria surveillance data, and particularly you talked about integration.
In malaria POR phase, a rigorous surveillance program is underway, and data is collected and transmitted real time, and response mounted immediately. We are following 1, 2, 3 strategy for that. When a case reported, where data is reported within 24 hours, and case investigation will be done, begins within 48 hours, and into surveillance will start at the 3rd day. Are you asking innovations as well? So, into surveillance team has been transformed by data from country to online database. Headquarters main program data is mapped almost in real time on Google Maps and made available to regional malaria officers. To officers in each and every district. We have 26 districts, and they can catch their data, island-wide data, achieve online basis. I think these are the innovations we are doing up to now, and what else?
So you're receiving the malaria data separately, and using Google Maps as part of that. Yeah, thank you.
Thank you.
Dr. Prayuth. So I wonder if you could say a bit more about the challenges in Thailand. So having comprehensive coverage of the surveillance system, how can you do that?
Okay, even though in Thailand malaria is notifiable disease by law, but we still have problem with finding case in the community actually, especially along the border. There's a lot of asymptomatic case, microscopic case which is cannot detect by using microscope or RDT. So what we try to improve our surveillance system here to capture case quickly along the border. Currently, we are mapping foci beyond border, which is the foci that cover both Myanmar and Thai side, and then we establish malaria posts in that foci so that they can manage malaria in both sides actually. And we train village health volunteer to help on the proactive case detections using RDT. It's not high sensitivity, but I think it's okay with current tool now. And then they work together not only for treatment but also follow up the radical cure of VIVAC in those patients actually. So not only that, we work with a partner who work in Myanmar in conflict zone and try to mapping case with them to plan where we should put interventions such as ship bed net to another site so that they can have net to protect themselves. And that along the border, but the problem in our surveillance, how do we make sure that every high-risk population get equally services, especially like at household levels, whether all households have enough net. This is critical because we never know which household have enough net unless we do survey later. And when we do proactive case detections or foci investigations or reactive case detection, we never know whether our staff test people, the right persons or not. Do they test forest scorer? Do they test migrants? Do they test children? If we have high number of cases, this is the data that we lack. That's why we apply the application that developed by CHICE to mapping foci and household and high-risk populations so that our staff can use that information to provide services to the right place, right persons, and also use that platform to monitor the coverage of interventions and also improving surveillance system along the border itself. So it will be a lot of resources to do that actually, and need more collaboration from partner and also from donor to invest on management of border malaria. Not only along the Thai-Myanmar border. I mean, we need to do in other countries too, like Indonesia, Timor-Leste, or Indonesia with Papua New Guinea, something like that. So I think border foci is very critical, and improving of surveillance and case finding, case detections, and provide services. It's very important for malaria elimination in future. Yeah.
Thank you. So come back to Dr. Wesley. Just looking ahead, what do you see coming for development of the surveillance system in the next few years?
Okay, thank you. I think the main developments that we are actually focusing on now is with the upgrade of the DHIS2 system. It only tracks the number of cases and all this. And now we are in the process of also building this with the building system of also having the reactive case detection part to be also part of that part of that platform also. So I think this is one of the 4 resolutions that we've actually discussed. And the other one is also to how we can be able to manage the commodities in the health facilities. So what happens is that we have all these stock management informations in that line list, which is the paper-based, but we need these informations to be captured also in the system so that we can be able to map out clearly where the cases are and whether the commodities is actually educated enough to conduct a test, for instance, or to even treat patients. So this is also the additional information that we need to build into the DHIS2 platform with support from the health information system within the Ministry of Health and also WHO and also the developers. So we're actually working on that. And also in addition is to try and overlay also the informations on PEDNet distributions to also be part of that platform as well. So we want to, as much as possible, to have all the information to be really available in the DHIS2 system so that it's easy for us on how to manage the case, where the cases are, what happens, is the coverage of PEDNet enough or no in that particular area when we're dealing with high active foci areas, whether the commodities are enough in treating the number of patients and all this, or do we need to shift some of the commodities from station X to station B, let's say. So it's something that it will actually help us a lot, and we are looking forward to also create some dashboards at the national and also province so that we can be able to have this information really available on monthly basis based on the key indicators that we need to measure when we progress towards elimination. So I think this is the developments that we are on now, and we're looking forward to that, and we really want to have all these information in one system. So this is one of the things that we are working with. We've looked at how other Asian countries actually move on that. So I think Thailand is a classic example, also maybe Cambodia and also Indonesia and Malaysia. So we try and, as much as possible, to have that platform to have all this information in there. So thank you.
Great, thank you. So just finally, before we turn to the floor for questions, Professor Manuel, and if you'd like to say a bit about some emerging trends and highlight some emerging opportunities in disease surveillance data analysis.
Yeah, I mean, I'd just like to briefly come back to what Wesley said. I mean, the plans for Vanuatu, I think, are really in line with a lot of the ideals that you might have for a system that really integrates different sources. It's of course then the challenge is obviously upon you to really make it work, and I think it's very interesting in this geographical space, also the enormous difference, also what the regional director mentioned before, between countries. The challenges that Vanuatu faces is totally different, obviously, to the situation in Thailand. But I think there's a very strong move, obviously, to have as much as possible of data collection, reporting, digital. I think with networks becoming available almost everywhere. Again, I think on small islands it's a different situation, but this is certainly a trend that is going to make the availability of data, the integration of data much easier. There are very nice dashboard solutions in different systems that allow you to integrate different types of data into a platform where, as a decision maker, you can easily access the different information that are necessary for you to make decisions. I think, again, underlying much of that is the availability of the people who can do the different things. And I think the last point that I'd like to mention here is, again, to really also think of what are different partners that you have available in a country. And if we go back to what I briefly mentioned in my presentation on subnational tailoring, for example, you might not have the capacity to do all the things within your Ministry of Health or even within the government system, but there are academic institutions in a country, there are different partners that can provide some of the analysis as services to the government. So involving different partners to also do some more sophisticated analysis at different points in time, I think is a really good idea, as long as the drive comes from those who in the end need to make the decisions, because of course as a program you need to decide what is the information, what is the data I need for which decisions that are realistic in my country. But yeah, I think, I mean, we've come such a long way from, if we think 10 or 20 years ago, when there was no option to paper-based collection and shipping papers all over the country, and the situation has totally changed. But I think what our colleague from Thailand mentioned about the challenges, I mean, even in Thailand, of replacing, I think you said the mobile phones or the tablets, I can't remember what it was. It seems like such a small logistic problem, but in reality, you need to consider all of these small technicalities, small operational issues before you change to a different system, before you implement something that might look nice in theory, but in practice it has really its own operational challenges, particularly in countries that are small, that have lots of areas that are difficult to access. Yeah, thank you.
Great, thank you. So we have around 20 minutes to take questions from the floor. I think for everyone's memory, we'll take one at a time, if that's okay. But if you raise your hand, and please say which panelist you address your question to, or if it's a general question. Okay.
Good afternoon, distinguished guests from the 5 countries in the Asia Pacific. Good morning, the Asia Pacific region. I stand here as the Deputy Director of Public Health in one of those malaria endemic provinces in Papua New Guinea, which is East Vic province. I want to make only 2 comments. Firstly, eradication of malaria in Papua New Guinea starts with appropriate diagnosis. About time we reintroduce malaria microscopy, we cannot continue to go on with this RDTs. You might agree to disagree with me, or agree to agree with me on this proposition. Eradication of malaria, we have to be specific. Whether it is ovale, whether it is falciparum, whether it is vivax. And I want us to end malaria in Papua New Guinea. I want us to reintroduce malaria microscopy in this country, and we have to be parasitic specific, provide a parasitic specific, and we respond to it. That's my first point. Okay. Secondly, integration. I value integration in my province. Integration in this instance, we are the first PHA in this country to have the technical working group for healthy island concept. And as one of the 5 or so high malaria endemic province in this country, I want us to integrate a healthy island concept. I think my board chairman and my CEO, they are also part of the group that we have visited. when we integrate a healthy island concept, we speak the language about malaria eradication in high endemic countries like Papua New Guinea. Thank you.
Thank you. I wonder if we would like to respond about microscopy. Should we be using microscopy in place of RDTs?
If I may just make one brief comment, and obviously that is certainly not a decision that I'd be in a position to take, but I think it's good to consider that implementing microscopy, no matter whether it's in Papua New Guinea or elsewhere, it's really a major effort to ensure that the microscopy services are always available. And I would say that it's much better to have RDTs available everywhere, which in PNG we do now have, than to struggle to set up microscopy services and in the end not manage to actually do it. So of course, if you are able and have the resources and everything to implement microscopy everywhere, I think there's nothing wrong about that, but to me, the question would be, in many places, is it really realistic or not?
Yes, thank you. I think just to add on to that, it's also one of the agendas that we also have been discussing a few years ago. Vanuatu was once having the 30% of microscopy services stations in most of the health facilities, like our colleagues in the Solomons, when we still have more funds from the Global Fund itself. So we were funding microscopists in all these health service stations to conduct microscopy services. And it really works well in terms of diagnosis and differentiating the species type from each other. And it's still maintained itself as the gold standard. So it's one of the things that I think we need to try and re-evaluate it and see the difference on how microscopy maybe works best as compared to the RDTs. Now we do not have that in most of our health facilities. They are all gone because the funding is actually decreasing from time to time. And what happens is that we now slowly have this number of cases, even though we still have these RDTs in places. We have come across, I'm not really sure whether other colleagues might also have come across that. We did have some issues with the RDT sensitivity in our countries. I'm not really sure whether our colleagues in the Solomons and PNC have also experienced that also. So we tend to have this false positive, false negative being reported with a batch number that has been shipped from the supplier. And this is really, really important. It actually demoralizes the staffs and also us to try and as much as possible to really explain why the patient is probably in a coma or in a shivering state whereby we're supposed to treat the patients. But the test tends to be false negative. And we have scenarios for that. We've actually documented that. And we've actually flagged it out to the PR and even the supplier. And Dr. James Kelly is part of the discussion. We even tried to send the batch to Manila for retesting, and yes, they've confirmed. So I think we have some issues with that also, as I speak, and we're trying to move from one test to the other. But that's again, like, the more we move from one test to the other, we have to think of the end users, which are the nurses. They are not only dealing with malaria, they also deal with other diseases as well. So I think we need to take into consideration. If we were to go back and say, okay, let's go back to microscopy as a gold standard, if we were to mean elimination as the real business for these discussions, then it is very, very important. Yes, because finding the last case, we need microscopy. I'm not really sure. I'm not clinical, but I can actually confirm that, yes. So I think this is very important discussions. I hope this is supposed to be part of the VIVAX working group discussions, but I'm actually just giving some insights on how we actually also experience the same scenario as our colleague in PNC and maybe the Solomon Islands as well. Thank you.
Okay, because this is a section for surveillance, so I leave the microscope in the afternoon. So I have two comments for the surveillance. In malaria control phase, surveillance used to be made for the surveillance data for decision making. However, for elimination setting, the surveillance data, not only for this, but also more important is a guideline for action. So I always using surveillance and the response as a key intervention for malaria elimination. So now many countries using 137. 137 original is from me. So this is just only for elimination, not for malaria control setting. They focus on three key points. So first, find case as early as possible. So this is the diagnosis, treatment, reporting. So this is one. The second is find the fossil as early as possible. We through case investigation and classification, looking for where is the fossil. So this is three. The seven is clean the fossil. So we need to clean the parasite in human body and kill the positive mosquito in fossil. So this is what we call seven. So all of this period, there should be considered the sporozoonic period in mosquito. So this is from gametocyte to sporozoids. So we need to this action before next transmission occurred. So we can using 137 in China, and also we're even using 1714 is no problem. So this should be considered before the becomes a sporozoite. So this is we using this one. So second point we talk about the now is we also similar like Thailand. We have a big trouble for the cross-border malaria because due to the political issues, Myanmar have an outbreak of the vivax malaria, not only in Myanmar-Thailand border, but also in China-Myanmar border. So we face a similar problem. To solve this problem, the 137 is not enough, so we need to add another one. So we have now the new strategy we call 3+1. Especially for prevention, re-establishment, cross-border malaria transmission. So now time is very short, limited. So maybe next time we can find the time to share the experience, how after elimination or prevention re-establishment, the cross-border should be the major challenge. No, this is not only now in Thailand and China. Maybe for many of the countries, we will face similar problem. Yesterday, we also talked in this region, also have a similar problem. Maybe we can share how to strengthen the surveillance and the response to solve these new emerging challenges in the future. Thanks.
Yeah, I have discussed with Professor Kauchi about the problem along the Thai-Myanmar border, actually. So what we try to do, it's similar to what he's talking about, but in Thailand, we may be more, the situation may be different from China, actually, because we still open border, people still freely crossing. So in Thailand, where we have a high number of cases in one province, we back to malaria control until the case load is down to malaria elimination levels. Then you back to do 137 or 3+1, like Dr. Kauchi mentions. So, but basically, the border malaria cannot manage only one side. We need to manage another side to whatever. Even they have conflicts, we still need to find a way to provide services in another side, and finding more cases, especially a symptomatic case, and try to manage and do more vector control and preventions, especially for mobile migrant populations, which is unpredictable and need more resource, which is, I think, partners, including WHO, Global Fund, or whatever, we need to invest more for in that situations. I mean, for example, net distribution, you cannot count. This net will be used for 3 years. I think if you find migrants, we need to provide one net. You don't need to consider whether they have net already, because they're moving and then they might lost net. So that's what I mean. The contingency plan, flexible plan, it's very critical in that situations actually. Yeah.
Great, thank you. So I'm afraid we're out of time. I'm going to do a quick wrap up and then just ask the chair to give a close at the end. Just a few points to highlight. So we've heard the importance of collecting the data that's needed, but also the benefits of really detailed data, and particularly integrating that data together to guide decisions. That data obviously needs to be accessible. It's critical to have people in capacity to collect and use that data effectively. But we've also heard about the challenges of resource constraints, and also with integration potentially losing focus on malaria and resources being diverted elsewhere. And then also finally about the challenge of cross-border malaria and the need for data sharing and information across those borders. So I'd just like to thank the panelists and thank the audience, and then hand back to our chair.
Just quick point, 2 points. One is about we have learned a lot more, learn more on data integration, especially data or information for action, to use for action, for better manage our program toward elimination, even third eradication. So with this, I thank panelists, moderator, and audience for your participation. So with this, the session brought to close. Thank you very much.